Welcome to our education, Exploring the Patient Journey. Let's talk about ILD and IPF. My name is Amy Olson, and I'm an Associate Professor of Medicine at National Jewish Health in Denver, Colorado. This is the third in a series of modules on idiopathic pulmonary fibrosis. The modules in this curriculum are designed to be completed in sequence. This final video will discuss the importance of early referral and treatment for IPF. To review, Mr. Joe is a 67-year-old former smoker who presents with a dry cough for 18 months and progressive shortness of breath on exertion for the past year. His cough is worsened with ambulation in the morning. He's had a history of reflux but thinks it's relatively controlled. He had asthma as a child but does not note wheeze or chest tightness. He also had a cardiac evaluation at the onset of his cough and was told his heart is healthy. His evaluation and workup showed that there were no identifiable causes for ILD. If you'll recall, his serologies were negative. A UIP pattern was clearly present on high-resolution CT scan. Therefore, a surgical lung biopsy was not needed to confirm a diagnosis of idiopathic pulmonary fibrosis for Mr. Joe. The disease course with IPF is variable and unpredictable and can be punctuated by acute exacerbations. As noted in the first video, the median survival time from diagnosis is 2 to 4 years. There are patients that have a rapid progressive course, and there are other patients that have a slower course of disease. However, at the onset of their diagnosis, we are unable to predict the clinical course. In addition, acute exacerbations, which may be lethal, may punctuate the course in either rapid progressors or slow progressors. The first acute exacerbation arrow is a decline, while the second acute exacerbation arrow is a lethal event. When having a conversation with a patient that has been newly diagnosed with idiopathic pulmonary fibrosis, it's important to spend adequate time explaining the prognosis and assessing the patient's preferences and values. The burden and morbidity of IPF can be emotionally overwhelming and will likely also impact family members. Each patient with IPF is different. The provider should be sure to consider physiology, exercise tolerance, radiology, and pathology when choosing a treatment course. Patients who are candidates for lung transplant should be referred early in the disease course. There are 2 FDA-approved therapies for patients with IPF, pirfenidone and nintedanib. Pirfenidone has combined anti-inflammatory, antioxidant, and antifibrotic actions, although its exact mechanism of action is not known. Nintedanib is a tyrosine kinase inhibitor that suppresses multiple signaling receptors involved in lung fibrosis, such as fibroblast growth factor receptor, platelet-derived growth factor receptor, and vascular endothelial growth factor receptor. Both pirfenidone and nintedanib have been shown in large phase 3 trials to significantly reduce lung function decline in patients with idiopathic pulmonary fibrosis compared with placebo. It is important to counsel patients about expectations with these therapies. They are not curative, but slow disease progression. The availability of these agents has transformed IPF patient management. Engaging in shared decision-making between the patient and physician is critical to allow the consideration of the patient's preferences, values, and concerns, and provides an opportunity for the physician to share information about risks and benefits associated with potential treatments. This process applies to disease-modifying therapies such as pirfenidone and nintedanib, and also to treatments for symptom management and comorbidities. In summary, for our patient Mr. Joe, and for all patients with IPF, it's essential to note the importance of a comprehensive disease management plan. Some things that we all need to work on together include treating comorbidities to prolong life. These can include gastroesophageal reflux disease, sleep apnea, coronary artery disease, pulmonary hypertension, and venous thromboembolism. Supplemental oxygen, drug treatment, and pulmonary rehabilitation are also important to consider. Finally, in order to discover newer therapies for future treatments, We also need patients involved in ongoing clinical trials. Some key take-home points to remember include, for patients who present with shortness of breath and chronic cough, it's important to have increased awareness for the potential for IPF and to rule out any known causes. The importance of physical exam findings with bibasilar inspiratory crackles and HRCT findings are needed for an accurate diagnosis of IPF. Early referral and initiation of treatment are important to optimize outcomes in these patients. Thank you for joining us for the discussion of ILD and IPF. To receive CME credit, please follow the link